How would the social workers handle that one person who's number 17 and doesn't have access to the necessary resources?
Thank you so much, Dean Dafati. Social workers first would start off by assessing what's happening with that individual, and certainly try to find a place that they can get treatment. But also, they would also think about in terms of advocacy. How do we begin to contact our congressional representatives and let them know about the problem, not simply say it is a problem, move beyond problem identification to advocacy and looking at this. But I also wanted to go back to a moment. We often talk about deaths. People live with opioid abuse and misuse. Entire family systems are harmed by substance use and abuse. So we have families who become fragile, and so we not only need a system to treat the person, we need systems in place to treat the families and what's going through that. So number 17, we would certainly give priority to. We start where the client is as social workers. But we would also realize the family unit has to be maintained, the integrity of the family unit. So we would begin looking at the strengths of that family. Just because I have a substance that is in control of my life at the moment doesn't mean I don't have strengths. I don't have relatives that I can bring to the table. So we would start looking at the entire availability of resources and see what we can bring to the table as we fight for justice. Something else that really concerns me, some people need opioids.
Yes, absolutely.
So I'm somewhat concerned that as we solve this problem, we could risk having people who need pain medication not receive it.
That's right.
Because we are sort of closing a door, and as we know, lower socioeconomic individuals are most at risk for that already. So we have to really think about pain equity, you know, how we manage pain. And there are people out there who don't have a high quality of life because they didn't get prescribed the most effective medication. So that's part of the social justice lens and the dignity and worth of all persons that we often talk about within the School of Social Work.
Absolutely, and I agree with you 100%, because from a pharmacy standpoint, we certainly need to work hand in hand with the physicians, the nurses, the social workers in terms of treating the patient. And so if you don't have a pharmacist working with you in the hospital, it's important that you request one. And if you're having trouble with that, call us and we'll be happy to fix that for you. But the PharmD is equipped and trained, and since we're talking about education and solutions, equipped to be able to handle appropriate pain management for a patient in collaboration with the physician in order to make sure that the prescription works and that the home situation is just right, in order to make sure that we're successful throughout. I think we need to consider that with the pain clinics. I agree with you. If somebody follows the prescription appropriately and they're honest with what's going on and whether the prescription is working or not, then we shouldn't get into those situations where it now becomes an addiction, and addiction will be managed in a different way. And I know you have.
I think this is a key training issue across all the medical sciences and allied and health sciences and social work, which is how to train people to be able to understand what's pain, how do we treat pain appropriately, how do we try to manage the treatment of pain so that we don't encourage or allow people to become addicted to the substance. But how do we still manage the pain so that people can get good quality of life? And then as we identify who's running into problems with the medications, how do we help them cope with those problems? And that's a enormous educational issue. And it has to cut across every aspect. There's no one who goes to medical school or nursing school or social work school or pharmacy school who doesn't need to know those issues and get a lot of training in pain management, diagnosis, addictions, and the crosstalk.
And I think that
I'd like to also add, as I read, there's a difference with gender. So women become addicted more easily than men do. So we need to have that consideration on the table, that we're not simply disregarding the person you know, as we sort of move forward with the treatment. So that's what I mean when we talk about culturally competent and sensitive practice. But if you're prescribing the same thing for a woman as you're prescribing for a male, it could be a larger problem. And so we really have to bring that to the forefront so that we get the best treatment.
Yes.
Dean Crew, I think you're absolutely right. The other component of that, though, is when you talk about culture, there's also a difference in culture. And as we all know, as educators, pain is subjective. So what I feel my pain level is very different, maybe very different than your pain level. So I think that the cultural component pieces of background, of African American pain to some other type of pain or whatever is very different. Male versus female, very different. And being subjective, that shouldn't hurt. Well, it does, and it's very subjective in terms of you can't put a number. I mean, you can put a 1 to 10 number on it in terms of a Likert scale, but in terms of how that feels to me, what may be a 1 to me, maybe a 10 to someone else. So that whole component of how the physician or the prescriber looks at the subjectiveness of pain and how we actually measure that really makes a difference. And that's something that we have to educate our students on at Howard in terms of where we are and those who are actually in the community and the people who are using those components in terms of learning how to have the pain related in terms of subjective versus objective.
Good morning. I'm Richard Schottenfeld. I'm the chair of the Department of Psychiatry and Behavioral Sciences at Howard University College of Medicine. I'm delighted to see you here. I'm also going to be chairing this panel discussion. Let me introduce our panel, the members of the panel. I believe Stacy Ward Charlery has just headed out. We have Dr. Edwin Chapman, Dr. Janice Edwards, and Mr. Oval Miller. And what I think we'll do when each of us comes up and talks, give your own quick background. Why don't I start? We're pressed for a little bit for time. We're going to compress this session, but we're going to get a lot of discussion and information in. I wanted to start by setting the stage for the role of treatment in addressing the opioid epidemic, and wanted to start with just making a few clear points so that we understand why we need treatments and what roles it will play and some of the essential ingredients. And you've already seen slides, so I don't need to show them, pointing to the explosion in use and overdoses associated with opioids. So I want to be thinking about, once people have developed the disease of addiction, of an opiate use disorder, what's going on here? And I think the key points are that, if we can go back, there we go. Opioids affect the brain, those mu receptors and other receptors that opioids attach to in the brain. They have initial effects, which for many people, for almost everybody, produce pain relief, extraordinarily important, but it also can produce intense euphoria, relief of depression and anxiety. Persistent use, and this is where some of the problems come in, persistent use causes persistent changes in brain functioning. And those persistent changes are part of what underlie the hallmarks of addiction. So the hallmarks of that intense drug craving, the desire to use, compulsive use, even when you don't want to use, when you hadn't intended, a single-minded focus on getting the drug, on using, exclusion of your normal rewards, and a dampening of the impact of the things that generally bring all of us great pleasure. And then to frame it, is that as we think about treatment, I think of it for opiate use disorder as medication-assisted treatment. And it's quite similar to treating other chronic relapsing medical disorders. such as diabetes or hypertension. One role, if we have effective medications, is to use them for their effects, and they're still an incredibly important role for all of the changes that needed to be fostered in how people live with their disease and manage it better. So what's at stake? When you look at any number of follow-up studies, what happens when somebody is opiate dependent? What happens when they enter treatment? This is the 33-year follow-up of heroin addicts. So it's back in the 50s. The results are going to be the same today, is that 50% die during that period of time. Most of those excess deaths are due to the opiate use disorder. Very few achieve long-term abstinence on their own. A sixth of those who were using at the 20-year follow-up become abstinent, so people can become abstinent at any point in time, but abstinence is often unstable, that people can relapse even after prolonged periods of not using. And if we look more recently, what happens if you bring somebody into a detox program or even a 6-week residential program, but you don't provide them effective medication-assisted treatment afterwards? You see extraordinarily high dropout rates, relapse. The different lines show if somebody stayed in the program, if they completed the program, about 40% managed to be abstinent for the 6 months. But when you look at all the people who enter the program, it's only about 5%, 5 out of 100, who stayed abstinent. And so during that period of time, most relapse within the first month, and that puts people in an extraordinarily high risk for overdose. The impact, what makes opioid addiction so persistent once somebody develops it, one big factor are the persistent changes in the brain that come from the opiates. And now let's talk very briefly about the role of medication-assisted treatments. What do we mean by it? It's the use of a medication to help promote recovery. There are really 3 medications now that are approved for medication-assisted treatments. Methadone, which is an opiate, buprenorphine, which is called a partial opiate agonist, and the long-acting injectable blocker, naltrexone. Medications are a platform to support recovery. They're not the full treatment alone, but they support recovery, and there's extensive evidence that the use of them reduces drug use, reduces overdose risk, reduces mortality risk, infectious disease transmission, and the evidence, long-term evidence of safety and effectiveness is strongest for buprenorphine and methadone. How do they work? So a couple of key points, because this is often misunderstood, and it's part of what I think creates stigma against using a medication as part of the treatment of a substance use disorder. Once-a-day dosing, or even less for some of the long-acting injectable formulations, creates steady-state plasma levels of the medications. During that period of time, there's no rush, there's no nod, there's no withdrawal. Additionally, at sufficient doses, in addition to preventing withdrawal, methadone and buprenorphine and injectable naltrexone can help reduce craving, and they can block the euphoric effects of drugs. So people don't get the rewards, decreases the likelihood they will want to keep using. This little schematic that comes from way back, Vince Dole and group did it, looks like, what's it like to have an opiate use disorder, to be addicted to opiates, and what's your mood like throughout the day? One of my colleagues thinks of it as being stuck in a turbulent sea. Your mood, your thinking is affected. At times you're clear, and then you're underwater. You're struggling, then you get clear. You're going up and down. It's hard to think, it's hard to focus, and you're mainly looking for how you can get the next bit of drug. And what's it like to be on medication-assisted treatment, where you really get a leveling out of the mood? You're not going through this incredible chaos. You're not going through withdrawal. You're not having intense craving. And for the first time, you can begin to think and focus and figure out how to change life and how to engage in full recovery activities. Last set of slides that I wanted to show is just a few to look at how effective is medication-assisted treatment. And one way of looking at it is to look at what happens when you ramp up the number of people you treat with medication-assisted treatment and what happens to overdose death rates. And so as Baltimore did this in the 1990s to the mid to late 2000s, the overdose rate shown in red plummeted as the number of people entering treatment increased. The same thing's been found, say, in France, which engaged in a massive campaign to extend and make easily available medication-assisted treatment in the face of their epidemic. And so the dots and that decreasing line looks at the number of overdoses, and that's decreasing over time, and increasing over time are the number of people entering treatment, engaging in treatment. And this almost identical looking slide just shows what happens on crime as another drug-related crime, which is another indicator of the impact of treatment. As you make treatment more available, make effective treatment more available, you decrease criminal activity, and of course you improve family functioning, you improve people's lives. So my last slide is what I think is one of the key challenges that we face as a society. Worldwide, only about 8% of the people needing effective medication-assisted treatments for an opiate use disorder get it. In the United States, it's less than 20%. Even as we've increased the numbers and the availability, we haven't kept pace with the increased need for treatment. And questions that I always have is why, when we have an effective treatment, aren't we using it? Why aren't we making it more available? Why aren't we addressing better all of the factors that prevent and decrease the utilization, whether it's financing, training for physicians and healthcare professionals to provide it, addressing stigma that keeps people from using it? How do we go about making those changes? We'll come back to this. This is some of the general questions that we've been asked to consider as part of our panel discussion. But I think I'm going to turn it over to the next person on the panel, who I believe is Dr. Stacy Ward-Charlery. Do you want to come up or do you want to talk from there?
I can talk from here. So I don't actually have any formal slides to present, but more so along the lines of some of the discussion questions here. So if anyone else has slides, if you want to do that first, then we have a discussion at the end. Sure. So I'm Stacy Ward-Charlery. I'm a informatics pharmacist with Short Scripts. My colleague Ken Whittemore presented earlier today. So just my general comments on medication treatment here to address the opioid use epidemic. I think it's a piece of the puzzle that we don't want to forget about. So we talked a lot about how do you prevent some of these patients from becoming addicted. We have different approaches in place. But for those who are addicted today, we can't ignore them, and we have to find a way to treat them. And I think we have some effective medications out there to help with that, and we have to make these programs and these options more available to our patients. And so right now, a lot of these are within inpatient facilities. There are different opioid treatment programs out there where the drugs are accessible. But is that really reaching all of our patients today? Are we reaching the patients that may not know they're addicted? And so that's why I feel like with the pharmacists on the front line and other healthcare practitioners, we need to do a better job to recognize those patients who are addicted today and refer them into this treatment or get them into a program. And we have to do a better job with removing the stigmas with these programs, because I think that's one of our discussion questions today. But I think there is still quite a bit of stigma with, now I have to go into a program. And so if I have to go into this program, that means I have to admit I have a problem. And I think that we have to overcome that with our patients today and recognize those who are at risk and get them to the treatment, overcoming some of these barriers in terms of the stigma, in terms of going to enroll into an addiction program, going to enroll into an outpatient therapy program. And so I think there's much work we need to do there in terms of education. I am a little bit partial to data in my role, and I feel like if we can really, Dr. Miller talked about this earlier, but get more advanced in terms of our predictive analytics to help us identify those patients that are at risk. I know those in the pharmacy and the front lines, you see them, we come to a pharmacy, you get that feeling when you know this patient is probably wanting to fill their prescriptions too soon, and you get this inkling that maybe they're addicted, and maybe you're turning that patient away. But where's the follow-up? Where's the follow-up back to the provider? Where's the follow-up back to whoever prescribed it to them to say this patient is at risk? And so that needs to occur in the front line, but we can also leverage data. We can also look to see, those patients that are at risk by maybe they're prescribed several different opioids by different providers, so your doctor shoppers. Or maybe it's one provider, but they get these prescriptions time and time again, and it's been refilled time and time again. Maybe they become at risk. Or maybe it's those that are on the triple threat, where you see them with the benzos or you see them with muscle relaxants. Maybe they're the ones at risk. And so similar to what Dr. Miller said, as we get have more better data and become more predictive, we can identify those patients and refer them or get them into the help and get them to receive these medication-assisted therapy.
Great. Dr. Chapman?
Need my slides up. So, I'm a 1969 graduate of undergrad at Howard. 1973 medical school. I did internship, residency, fellowship, all in Washington. Actually married a nurse from Old Freedman's Hospital, and my son is a graduate of the Howard School of Business. So I've been practicing medicine for about 40 years. In Washington, and my office is on Benning Road. I'm an internist, did a fellowship in cardiology, and you wonder, how did I get in substance abuse? But when you observe the neighborhood that you're in, my father always taught me that you had to adapt, and survivors are the ones that will, adapters are the ones that will survive. So Dr. Schottenfeld has already talked about France and Portugal. France and Portugal have the best outcomes in terms of opioid treatment, starting at the same starting point that we did. So at the top, you can see the death rates in France are about 6 in Portugal, 7 in France. United States is over 300 for the same demographic. Over the same period of time, HIV rates plummeted. So why not just start with the best? We've already talked about the decrease in crime, and this just shows that France predominantly used methadone or buprenorphine, and Portugal used methadone. So both had nearly the same results. So how can we bring that model to the District of Columbia, where incarceration was the treatment of choice for over 50 years? So we developed what we call a loss mitigation model. And if you look at the cost, this is the cost of not treating a patient. So that you have criminal costs, either you're in jail, you spend $35,000. If I have a patient with a $50 a day drug habit, they got to get $100 to spend $50. You multiply that out, it's about $35,000. And you multiply that times 300 patients, that's about $11 million. So I got 300 patients, I saved the city $11 million in crime, because they're either going to go to jail or they're going to commit a crime. The other thing is the medical costs go up, infections, overdoses, et cetera, and then the social service costs. Patients are homeless, and homeless people have an organic footprint as well. So those costs, if you add them together, will come to about $105,000. So treatment costs about $15,000, and that's pretty high in terms of reimbursement, adding in the cost of medication. So every dollar spent on treatment saves $7. So call this a loss mitigation model. You're either going to pay now or you're going to pay later. You either spend $15,000 on treatment or you're going to incur over $100,000 in costs per year on these patients. So why don't doctors treat? Well, nobody likes these clinics. The doctors in my office, in my building, saw these patients coming in. Oh, why is he bringing all those folks in this building? The insurance companies don't want to pay that cost. These patients cost about 4 times the average cost of a patient. So the average cost of a patient is about $10,000 a year. These patients cost around $40,000 a year. Then you have DEA inspections, et cetera, because these medications are highly regulated. So incarceration ends up being the alternative to medication-assisted treatment. So what are the obstacles? Well, all of these entities have their own lobbyists and their own special interests. And they use those lobbyists to control regulations, to try to incur obstacles or barriers for treatment. So the insurance companies have embedded prior authorization organizations that will block the ability for us to prescribe. You have to call them, you have to send them information, and they might delay 2 or 3 days before they approve the medication, which means that on my end, I might have to hire somebody to fill out those forms and make those connections. So that's an added cost. So all of these are barriers to treatment from a provider side. And then you can get audited. We get audited based on expenses, based on from the DEA. You're not supposed to go over 100 patients. I've known doctors who had 105 or 110 patients and the DEA hit their office. So the good news is that the chairman of FDA is pushing medication-assisted treatment and recognizes the importance. And this is Dr. Nora Volkow, the head of NIDA, who made a comment in the New England Journal of Medicine several years ago saying that systematic prescription of inadequate doses of MAT medications further the lack of faith in MAT since the resulting return to opioid use perpetuates a belief that they don't work. So if you're not given enough medicine, then it looks like the patient is not getting better and the patients drop out. So I've used both methadone. I ran a methadone clinic for 12 years, and I've used buprenorphine for the past 11 years in my office. Initially, reluctantly, but then got very comfortable. So this is just a chart, state by state, that shows the differences in the maximum dose that different states will allow, from 8 all the way up to 32 milligrams. So the state of Maryland, about 4 years ago, a new farm benefits company came in and forced the doctors to reduce the medication down to 16 milligrams. So unfortunately, Johns Hopkins was one of those institutions, and they said, fine, we'll study it. So they did a follow-up research to see how many relapses they had and how many dropouts. And they published that study and showed that 16 milligrams was not enough, that there are patients who need more than 16 milligrams and that we're probably doing harm. So at the same time, that happened to my office, and we were already in the midst of fighting to get those rules changed. So we know that every patient does not require the same dose. I happen to be allergic to morphine. So that gives you a tip if, as Dr. Schoenfeld showed, that 1 out of 5 patients takes a opiate for over a week, they'll have a problem. So it tells you right there that that there's a genetic component to addiction. And so now we're looking at patients. Patient walks through the door, they all look the same. But we know that medications are metabolized through the liver, through the cytochrome P450 system. So you have slow metabolizers, intermediate metabolizers, rapid metabolizers, and ultra-rapid metabolizers. Well, we've known that for methadone for a long time. We knew that we had slow metabolizers and rapid metabolizers, and some folks needed higher doses, and some you needed to spread the dose out. So just phenotypically, watching my patients, I realized that there was a subset of patients, a very large subset of patients that needed more than 16 milligrams. And if I could get them on the right dose, they would stabilize. So we published a paper on the first patient, and we have 144 other patients that we're studying. So how do you break the cycle of the prison industrial complex? And we all know Michelle Alexander's book, who really brought out the problem that the use of drugs was a means of enslaving folks in our community, so they went to jail and they got long sentences. So now it's our job as medical providers to increase the treatment side of the equation, because if there's no place to go, they're going to end up in jail. So not being a psychiatrist, how do I get all the services I need in my office? So this is just a diagram of how my relationship to Howard. I came back 4 years ago under the Department of Psychiatry, not internal medicine, and you can see from this diagram that my office does primary care and substance abuse. We have another office that does primary care, substance abuse, and infectious disease, but we don't have a psychiatrist. So how can I link my office to social work and psychiatry? So the idea was to put in telemedicine and use a telemedicine connection between the offices and share services. So that was a basic design. This is a construct of where we are now. We've set up several offices in the city, including far southeast Washington, one in United Medical Center, and connected them all using electronic medical records and telemedicine. That enables us to bring in care coordinators. We have access, or the School of Pharmacy has access to my records to do pharmacogenomic testing and reconciliation. We have a management team that sees every record that manages my office from 1,000 miles away. They see everything that goes on in my office. And we were fortunately able to get the District of Columbia to change their policy on medication treatment and raise the dose from 16 milligrams, and that now allows us to go back to 32 milligrams. So this is how it would look if you were connecting all of those sites. And finally, this is the team, but there are a lot of other pieces that we'll talk about. Thank you.
I'm not going to start with slides, but I'm Janice Berry-Edwards, and I'm from the School of Social Work. And first, let me just say that the School of Social Work is very happy and to be involved in this critical discussion and this opening dialogue of a very serious epidemic that actually because we are in the trenches in terms of how we work, we see it on a daily basis. But our framework as social workers is to really look at the client where they are, we start where they are, and we stay where they are as we move them along the process of healing. But our framework is to examine the client from a biopsychosocial, physical, environment, and spiritual lens. So our engagement really begins there. And we think that framework as a basis is critically important in understanding the multiple and overlapping nature of this epidemic, as well as the social and structural determinants that are contributory to the problems that we're seeing in the opioid epidemic. So as we work together, I'm hoping that we can all struggle with the unfolding of a deepening of our understanding of the connections between these social determinants, the structural and the social determinants, and the relative importance of them in terms of how they contribute to the opioid epidemic. There are some points that we would like to also raise is that we have to work with the families and the community systems. Families have a great deal of difficulty with getting their family members into treatment. Also, there are concerns about the lack of reaching out to families to include them. And as a result of that, there's a maintenance of their addictive behavior by excluding the families and the communities in the treatment process. I think we also need to integrate into the discussion of the client all of those that are connected to the client. That would include not only their community systems, but their provider systems. The other thing is, because we also start from a strengths perspective, is that we need to understand and support our client from the understanding of their strengths and examining our own attitudes towards the client and their addiction. So if we can integrate that into the discussion, I think that's critically important. Our response has to be proactive, and finally we have, because of all the changes legislatively in the federal system, we now have the ability to move more quickly into addressing the problems. Again, working with the families and the communities, they are a critical aspect of their resilience, and the families are survivors. How we engage with them is critically important. So thank you, and we look forward to continuing our participation in this important discussion.
Thank you. Thank you. I've listened to the presentations. My name is Oval L. Miller, Sr. I'm out of St. Louis, Missouri. I run a drug rehab program in St. Louis. I started that program 35 years ago. 99% of all the clientele that we serve are African Americans. We also have a program for women and children also in the shop. We opened up in 2010. I'm a little different than the presenters that I've met with yesterday and some today. I call them technocrats. They talk about things associated with the medicated assisted treatment. I talk about treatment. Majority of you probably, you know someone live in the inner city of Washington, D.C. in what we call the hood, the urban areas. That's who we work with. But let's kind of go back. I started in 1983 when I opened Basic up with the help of foundations like McDonnell Douglas, Ralston Perino, Monsanto, because what we offered was an abstinence-based program. Now, I know things have changed, and we're moving away from abstinence-based. But let's go back and think 1980-81, if you know, I guess I should, I'm 73, so 80-81 years, 1980-81, what was going on? Well, we had the AIDS epidemic that opened up, and we also had Iran-Contra. We also had Iran-Contra when our government saturated the urban inner city communities with drugs and guns. And then we had jail terms for everybody who got caught, and the jails got filled. During the time they saturated the community with drugs and guns, they eliminated all the resources. We used to provide treatment on demand. That's what's missing. When an addict comes and asks for help, and you tell him he's got to wait 2 or 3 days or a week to get help, then that window of availability opens and closes quickly. He's not going to return back, or she's not going to return back. So each time the African American community experiences the wrath of us not being prepared, and then we come now with the medication-assisted treatment. I don't have anything against that. Is that right to stand up? Sure. I don't have anything against medication-assisted treatment. But what's wrong with abstinence? African Americans have been treated for years and years and years with somebody else's idea of what it takes to get us right. We haven't forgotten the studies in Tuskegee. We haven't forgotten the studies in New Orleans with Dr. Heath at Tulane University. Now here we come with something new. Someone said, well, you know, let's dose them. Dose them first. What about counseling? What about understanding the cultural context in which the misuse or abuse developed? What about getting to the pain area? What's causing the pain? Instead of dealing with the symptoms. So you put a man or a woman on, I got guys in St. Louis who own 120 milligrams a day. 120. From methadone, I got guys who've had bad reactions to Suboxone and Subutex, and it costs $1,000 a shot for Vivitrol. $1,000. You get it once a month. And if you're not involved with a program like mine for indigent, the average person can't afford it. So we keep going back. Somebody is getting filthy rich off of our illnesses. And they keep coming up with a solution that doesn't fit the problem. How can you provide a service to African Americans if you don't understand the cultural context in which the misuse or abuse developed? We got 3 times as many liquor stores in our community, 5 times more advertisement in our community. 1 out of 2 homicides, drug-related. 8 out of 10 felonies where weapons involved, drug-related. That's the problem now. Don't give me no medication to make me sit somewhere and be quiet, because that's all the medication does. Well, give over 40 milligrams of this here, and he'll go over in the corner and be quiet and won't bother nobody. Our communities are saturated with gun violence all through the night. People unable to pay their bills, can't pay their rent. Children being shot, going out playing in the schoolyard. That causes stresses. And stresses create pain. And people need help. They want to find some kind of, how do you get off of drugs? How do you do that? Let me be a little bit more frank about it. I'm a recovering heroin addict. I was addicted to heroin for 12 years, a mainliner. I've been clean 36 years, and I didn't take no medication. I started this program based on the fact that I believed in abstinence. We have to legitimize abstinence in the African American community. We can't afford to go to sleep. We can't afford for nobody to give us no medicine so we can't respond and everybody take advantage of us. We've been taken advantage of for too long. Now here we're back in our community. People are dying. You're right, they are. But you ain't gonna help nobody dying if you give them medication and keep them quiet. Now, I'm not against medication. I told Doctor yesterday, for detoxification. Detoxification. The average guy you see on the street that's using drugs, they're not using heroin. They're using a mixture of all sorts of other drugs. They call them urban cocktails. Urban cocktails. They used to call them, the pharmacists call them Brompton's cocktail. A lot of the pharmacists have died too from taking all of those Brompton's cocktails. But I see that some of you are responding. You know I'm telling the truth. Don't be sitting up here using no big words and stuff and talking. You know what's going on in your community. You know what's going on. And you need some help. You want somebody to tell the truth. Can this thing be changed? Yes. But the people in the community got to care about the change. Got guys coming out of the penitentiary in 20 years, can't get a job. You know where the drugs are coming from? Have you passed by when the last time you drove by the senior citizen home and checked, see how many people come to visit the people in the old folks' home? You know, they get 90 to 100 pills every month. for pain. You know, Oxycontin, 80 milligrams costs $100 on the street. Surely it seems like it's an easy way for somebody to subsidize their income if they're getting $500 or $600 or $800 a month and somebody coming giving them $40 and $50 per pill. But you didn't go by to visit them. You left them in there. You know, they just lived to be old and nobody cared about them. When do we take an involvement in what's going on in our community? Our children, these kids are going around. I was at a restaurant this morning, and the lady was there at the hotel, and she was talking to me about Quaaludes, about sucking the candy off the Quaaludes and crushing the peel in the middle of and shooting and using that to get high. I knew what she was talking about. They were doing it back in the 80s. But it was white folks doing it. See, when I went to treatment in the 80s, it wasn't no black folks in treatment. Because treatment was $24,000 at a private center, $24,000. Care Unit Hospital was charging $23,000, $25,000 per episode. I went to St. John's Mercy Hospital, $24,000. I was the only black man in treatment. Everybody else in there was white. They were the only one who could afford it. So where did you send the black heroin addicts? To jail. To jail. Let's be honest. That's why we sent them. We sent them to jail. And we waited 10 years for them to get out. And then if they didn't act right, we sent them back to jail. Now all of a sudden, that's not, well, wonder why sending them to jail not the answer when white folks start dying. See, sending them to jail was when black folks was send them to jail, put them in jail. But now white folks done start dying. White folks done start going to their bedroom and finding their children dead. And that's not the answer this time. Why not? How come we not sending the white drug dealers to jail? Could it be that they're the people who funding the lobbyists that find themselves up here? You know the people who sent the 4 million pills into a community with 400 people. I know you know about them. Didn't you read about them? 4 million pills into a community that only had 400 people. Now that's straight out saturating. That's big time in there. All you gotta do is go on the internet. If you got a phone, an iPhone, and internet, you can order pills off the phone. They send them to you. So now I'm gonna get off. We want to medicate. We want Oval to be quiet. Don't say nothing, oh, but I'm 73. I've lived. I got a good life. My career. I know people gonna be throwing rocks at me. Hey, but I'm just real, man. I'm just like the rest of us. I come up in the South, hard times. I got a chance to make it. I went to historic A&M College, and I done all the things you're supposed to do. The mama said you're gonna be all right. And I got strung out on heroin. Then somebody loved me enough to say, God has saved you for a reason. We love you. And I was able to facilitate a change. And a change in other people. I've never had an overdose at my outpatient clinic in the city of St. Louis or in New Orleans, Louisiana, since I've been in operation. Never. Never. And I service robbers, murderers, rapists, sodomists. I've never had an incident where I had to call the police for some crime that was committed in my office. Because where there's respect, you can measure the effectiveness of your treatment. You got to respect the people first. I've never met a heroin addict that got up in the morning and wished he was a heroin addict. I ain't never met nobody. I've never met anybody that I hated so bad that I wanted them to be a heroin addict. And once you get on, this is the most controlling drug you ever had in your life. It controls whether you make love to your wife, put your arms around your children, whether you cry, whether you walk, talk, whether you have, they don't ever ask the question, when the last time the client had a bowel movement? That's the most important question you could ever ask. When the last time your client had a bowel movement? Because we do know opioids lock the bowels up. Remember we said medication first, didn't we? So when does a man or woman have a bowel movement? You'd be surprised the number of clinics that never ask that question. When you don't have a bowel movement, everything about you is messed up. See, a little simple thing, but that's understanding the cultural context. Culture is defined as behavior and problem-solving techniques mostly exhibited by a certain group of people, ways of worship, ways of burying dead, rites of passage. Counseling, which is treatment, is defined as any type of ethical activity engaged upon by the counselor or therapist which will bring about a change in behavior to the resolution of the problem. You can't do one unless you understand the other. So you can't just say, I want to go help somebody and don't understand the cultural context in which they evolve. And African Americans evolved from the fringes of American society. I don't care how much we say that I'm this, I'm DD this, and LD this, and MD this. The bottom line, you're a black man in America, and it's tough because you don't run nothing. And if we don't start teaching our young children to gather together and come together as a unit to address this, then we're going to have a generation of dosed children. Dosed. And then we're going to make excuses how come they didn't excel in life and how come they didn't do this and that. Times not changed. I know I probably offended somebody today, but I didn't intend not to. We got to quit. I probably, my friend that invited me, Dr. Etienne down in Andre, my friend invited, he's a Howard alumnus. Y'all probably could say, man, don't never bring Oval back up there no more. We have to be real. Even with the God that we say we love, we got to be real. You can't love God if you don't love self. The pathway to knowing God is through the self. So how am I going to help you if I don't know who I am? What is it that we want? I talk to my young man now. He's with me now. Andre. Man, when you believe in what you believe in, can't nobody take that away from you. People have been dying from overdose on this here medication first. People have been dying because we didn't inform the family about the side effects. We didn't inform the family that you can't take Suboxone and then shoot dope day after tomorrow. We didn't talk about that. We didn't talk about that Suboxone got opioids in it. And when they want you to stop taking it for 2 or 3 days before they put you on Vivitrol, so that means your body gonna go through physical withdrawal because you don't have that drug in you. We don't talk about that. And you can't expect nobody in the hood to be logical and responsible and predictable about some script you gave them that 9 times out of 10 they don't even read. What about Narcan? Well, people dying. Isn't that something? Black folks been dying day after day, year after year, and nobody come up with no Narcan. No, they didn't. It came out the other day. I was in Jeff City. $132 for a Narcan. We're going to give it to you all. Every program gets 50 or 75 Narcan. I said, well, how much it cost the families? $132. What black family you know gonna spend $132 on no Narcan to save somebody they don't even like? The average income in the city of St. Louis for 63108, which is the Jeff Vanderloo area, 1,500 families, average family size, a mother and 3 children, 4. 80% of them don't have a high school education, 85% unemployment. Now, Julian Castro reported this. I didn't make these numbers up. And the average income is $11,000 a year. A mother and 3 children. Do you think she's going to spend $132 on a Narcan strip for somebody who just went in her pocketbook day before yesterday and stole her last money? It don't make no sense. It don't make. I'm going to say this and I'm going to sit down. Let me see. You ever been around a person who had overdosed and you brought them back? You have to ask the EMT people about this. Isn't it strange that if you wake somebody up from an overdose, there's a 90% possibility they'll jump on you for waking them up? Check it out. Ask the EMT. They'll jump on you, be ready to fight you and hurt you. Wonder why? Could it be they had reached the ultimate state they were striving for, which is not to feel, and not to feel the ultimate state is death? Could it be that we pushing it to the side, that the situation is so bad in our community that people are going to bed at night and praying not to see the sun come up tomorrow morning? Could it be we've created that type of environment that people pray for death? We're trying to put it on something else when an environment is so crazy and so difficult that mothers are leaving their children in the cars. You think they're doing it on purpose? They're trying to escape the pain of hopelessness. We can ignore it all day long, but it's staring us in the face. You know, I'm 73, I got grandkids coming up, and I tell them all the time, hey man, Gramps gonna try to give you all I can tell you about it. Quit using those big old words, because people in the neighborhood don't know them big old words you're using. They don't know that. If we know we gotta go to school and we gotta learn all we can, but at least have the respect to be what you call bilingual. And that's the word, bilingual. If you're gonna talk all this here educated stuff, talk hood stuff too. I trust a man or woman who believe and trust in themselves and their people. Thank you.
Well, as you can see, we did not want to give you a single unified view of exactly how everything should work. And I think it points to what really underlies this, which is these are extraordinarily complex issues that involve many factors: culture, what people's lives are like. There's a reason why much of this is called diseases of despair, deaths of despair, because we have created conditions in which people are giving up and have given up, and that affects across the country. I think from a treatment standpoint, which is really what the panel was focusing on, it also brings out not that there's one treatment, but just as people from a lot of different walks of life can enter and become addicted, there are many different pathways to recovery, and we ought to be supporting all of them. And the other, just to be clear from at least my perspective, at best, I think of medication as a platform to help recovery. And not that this is the end and the goal is to get somebody on medication, but it is to keep people alive. One place that I might immediately disagree is towards the end. I don't think people want to die. I don't think that the person with a drug, with an addiction wants to die. And we've seen plenty of proof of that. Frankly, at the beginning of the HIV epidemic, and I was there too to watch it, I had a fair amount of despair that we'd never be able to get people to change their behaviors, because what I had learned was that an addict just wanted to die. But what we very quickly saw back in New Haven over a couple of year period was this huge shift among people using drugs from how they used, where it was about 89% injection drug use in '86. Within 2 years, it had dropped to less than half. And the reason was people didn't want to die. They wanted to use drugs. They needed to use drugs. They were addicted, but they wanted to stay alive. And I think that we can play on that as then helping people and their families enter recovery. I want to give people on the panel a chance to respond.
I want to thank you, because if we don't understand the context of the client's experience and the narrative of their will, whether it's positive or negative, if we can't hear that and we're not mindful in terms of how we engage, which you emphasized beautifully, then we're not going to win this. If we don't engage the communities, and if they're not a part of this discussion and a part of working towards resolution, we're going to lose this. So thank you. And you
and
beautifully
that's why
done.
the alumni, you know, Doc, what happened is we have a comprehensive program. But my monies I got to start basic came from foundations and corporations, McDonnell Douglas, Monsanto, Mallinckrodt. So what they did, unlike government-funded programs, they came at the end of the year and says, look, AO, we gave you $100,000. What'd you do with our money? So I had to hold on to the clients that I had served, and we created the alumni. The alumni is 31 years old. They meet every month. They provide jobs. They provide. So this is giving back to the community again. But I want to respond quickly. He says,
Absolutely.
He says, well, people don't want to die. Huh? Ain't that something? You live in an environment where you can't, everything is gone against you. People shooting, you can't find a job, police shooting and killing you. What is the reason why you want to live? You know, until we create that environment that living is worth living, then you're going to have young people who are desperate, and desperate people do desperate things. That's why they're out here shooting at each other. Life don't mean anything to them. A lot of the murders in St. Louis, they're not over $20,000 or $100,000. They're over $25. They're over disrespect. The community can't afford any losses, even respect. And we're shooting and killing each other behind trying to get some means of importance or fulfillment about life. So we have to give it to these young people. We ask for a truce coming into our office. You Crips, you Blood, you Disciple, whatever. Look here, we don't want to have none of this going on in the office. This is our safety haven. Let's get in here and make some changes. And those guys who are actually shooting and killing, we got the same thing with women. Women, I call them thug broads. They out there shooting and killing each other just like men. Anytime you get a woman standing on a corner slinging heroin from a corner, things are tough. And we can sit here all day long in these beautiful halls, but you got to go home. And in St. Louis, they shooting people going home, riding down the freeway on their way home. Just because you live in the suburbs don't mean you safe. Home invasion. So this is a problem. We all got to work hard. And like Doctor said, if you don't, then I don't know what to say. I'm 73, you know, God, what did it say, 10? Well, I got mine down.
So I'm only 71. so I'm just going to emphasize, when I came back to Howard, the design of the project was the index patient and the entire family.
Right.
When I ran the methadone clinic, the first thing I noticed, I had 3 generations. I had grandmother, mother, and daughter, all on heroin. So that my focus was a harm reduction model. I'm going to do whatever it takes to stabilize that index patient so that they can create a home environment for the next generation that won't repeat itself. We have repeated it in we've had 5 generations. We've lost 5 generations. Now we're seeing it in the suburbs. The same thing is repeating itself in the suburbs and the rural areas, so that now mom and dad are dead in the front seat of the car, and grandmothers and granddad have to raise the kids. So we're going to see the same diminution, and that's what the doctors from Princeton showed in the decline in life expectancy in this country. It's related to suicide, alcohol, and drugs. And it starts with economic decline, then mental depression, then the patients look for something to relieve that depression, and alcohol and drugs become that out. So I don't care if the patient stays on methadone, stays on buprenorphine for the rest of their lives. I got patients that have been with me in my office now for 11 years. The idea is to stabilize them so that phenotypically they look normal to the next generation, and they can function. So that's the only way we're going to be able to break the cycle. But my goal is not, to argue about abstinence versus medication.
No.
It's about stabilization.
But I think we have to have healthy dialogue. You're involved with a treatment entity that provides services to the African American community. I'm involved with one. We both done a lot of good things. I don't necessarily agree in the medication. I think back and say.
Well, let me just tell you one other thing. 60% of my patients have hepatitis C. The government doesn't want to treat them because it costs $100,000. So we've gotten over 100 to 150 patients treated for hepatitis C right here at Howard. I sent all the patients over to the infectious disease folks. We've convinced the government because those patients will infect somebody else in the community. And then 10% of my patients have AIDS. So you put those patients in jail, or if they don't have AIDS or hepatitis C when they go to jail, when they come out, they're very likely to have it, and then go home and infect their partner. So that's why D.C. ended up with the highest rate of AIDS in the country.
Now, let me ask the question. Does the audience know that a lot of times the people who own Suboxone will go in and get their dosage and then come to the street and sell their dosage? They've also done that with methadone also. Because if you're on methadone, you're what you call a registered addict, which is legal. They used to have what we call internal possession.
So let me just comment on that. The first thing that happens when one of my patients goes to jail is they take them off the medicine. So what you've done is create a black market in prison.
Right.
Okay? So the state of Maryland said, oh, it's the strips. The strips are easy to sneak in. We're going to take the strips out and give them pills. But that wasn't the problem. You created a black market. If I took you off of insulin or took you off of blood pressure medicine and put you in jail, then your insulin and blood pressure medicine would become a black market item because you need that to live. So when that patient comes out of jail, they're not on medication. They come back out, then they have to relocate a means of getting that medication, and in the first 2 weeks, you have the highest documented death rate, and these are young folks because their tolerance level is down and their cravings are up.
So just let me just finish at that point, and then maybe we'll open it up for general discussion. But the question of diversion, there's fairly clear evidence that as treatment becomes more available in the community, medication-assisted treatment, there's actually less diversion of Suboxone. Part of what we've created in our communities is something like jail.
Right.
Treatments aren't available. So if somebody's hurting and somebody's going through withdrawal and somebody's desperate, they're going to use what they can to prevent that. And that may be some of the medications. If we make the medications, and again, the experiment's been done, when we make those treatments more available, more easily accessible, actually decrease some of the diversion, and you get the health benefits. And again, medications alone aren't anybody's answer, and not everybody needs it, but they sure can be helpful, much like insulin is.
If they're monitored. Now, I want to ask the audience, when you ask questions, there are several centers in St. Louis, Missouri that dose. That's the term we use, dose. At any given day, you can come down on Market Street, and you may see 7 or 8, 15 passenger white vans parked out in front of this center. 90% of the people are African Americans. They're going in there for one reason, to get dosed. Now, I don't know about you, but it always concerns me that you got a line of African Americans walking up to this center. I don't know who in there doing, what they doing to them. Nobody in the community has checked to find out if they say they doctors. We don't know if they doctors or not. And they're dosing our people. Somebody got to ask the question, what's going on in there? We have a right to know what you're doing to our people.
So let me respond to that. So most methadone clinics are substance abuse only. They have some counseling, but they don't do primary care, they don't do psychiatry. So we changed that model, and we're changing it here in the district right now. My practice is actually affiliated with a methadone clinic doing the primary care. We found also that the patients in that clinic were not getting psychiatric care just like the patients in my office. So over 50% of my patients, over 50% of patients who are opiate addicted have a severe psychiatric problem.
And we counsel.
Let me finish. Let me finish. So that if you don't treat the mental illness, the anxiety and depression, the schizophrenia, et cetera, then you're gonna have those issues. Many of the patients that we see are, for the first time, they're getting blood pressure medicine. So if you look at the statistics, the average life expectancy of a person addicted to opiates is 51 years, okay? So when I did the stats on my patients, the average age was 52, 60% were hepatitis C positive, 10% HIV positive, over 50% had a mental health problem, not on any medication, and 43% are homeless. And when I say homeless, 16% were homeless on the street or in the shelter. Another 27% were
And so
couch surfing.
where did we get to?
Just
Where did
before
we
you
get to?
let me just ask, we're going to have probably 4 minutes for questions. I'll let you finish.
Yeah.
But if there are a couple of questions and people want to go to a microphone, go up to the microphone and we'll give
Now, I'm just
give
going to
you
make
a
this
chance
short.
to respond.
I'm looking to my left and I see the young people over there. You know, as we get older, we say, well, life expectancy at 55, 60 years old. They're not there yet. They're not concerned about that right now. They're concerned about how to get all they can get out of life right now. Whenever I hear someone say mental health for African Americans, ask yourself, let's try to stimulate these. Who does mental health for African Americans? I serve on the Minority Mental Health Board. It wasn't, 35 or 40 years ago, they said we couldn't have mental health because we didn't have no brain. We wasn't out of intelligence. Now, I didn't make it up. You can look in the book and see it. When you say cultural schizophrenia, or the person is suffering from paranoid schizophrenia, African Americans suffer from schizophrenia from birth. It's called black double consciousness. How I feel, how I see myself as a black man, how society sees myself as a black man. Every black man in this room has two personalities he has to deal with day after day after day. So if we don't get a clear understanding of what we're trying to accomplish, then our people are going to always be in stress. And that's why I was saying earlier, we got to talk in language that the young people understand too. What's going on, man? How you living out there? 77% of all the female cases of AIDS in the city of St. Louis are African American women. 56% were infected by a heterosexual black man. You mull that around and figure out how that could happen. That's 25% higher than a national rate. You can't get black women to stop black men from having sex without a condom. What's going on with that? Why wouldn't we talk to our children about loving life enough to say nobody could infect me like that?
I think mine is somewhat of a question, but I think more importantly, I work a lot with Dr. Chapman's patient. The reason why I have this affinity for the brother that is talking, because I have also been that activist. A friend of mine was killed in 1967 by a police officer on Minnesota Avenue. And I was right involved. They were fighting over a gun, about a 29-cent box of chocolate chip cookies. And he called me out and said, "Catfish, help me." I said, "Let the gun go. He's not going to shoot you." Right behind Minnesota Avenue, he shot my friend in the back. Out of that, I get a knock on my door because we start raising hell. And who was at the door? Marion Barry. And Marion asked, how could we help? We started one of the best programs that this country has ever seen, and that was Pride Incorporated. Because we understood that the families were broken. And the reason why I work with some of Dr. Chapman's patients, because a lot of that clientele has been left behind. Every generation stands on the back of the preceding generation. But now in our community, you see that that whole scale has broken down. When you talk about this restoration, it must have started. The most important part of a child's life is 0 to 6. What I am submitting to my good friend, we are missing that window. And so it's replicating and replicating and replicating. And so therefore, there are times that I can work with his patients and do a center-based coordination of services. I also was a little bad kid. I used to steal cars. I loved to steal cars. Even I couldn't drive, but I loved to steal them. And Dr. Chapman will tell you how many cars I have now that I paid for. But the reason why I say that, I was thrown into that environment of incarceration. And I know what incarceration does to you. It really gets you conditioned to live in jail and visit street because you have to become this animal to survive. So what I'm submitting for consideration, what I have to do, sometimes when I go into the family, I have to begin to support the family. And what Dr. Chapman is doing, I'm working on another lane and hoping that eventually I can get that person in that family. Usually it's that single mother raising them young warriors. And I submit to you, after that crack epidemic, we used to be called what? The crack capital of the country. So now we are seeing the byproducts of that. When you talk about, I bet you $1 to a donut, maybe the parents that you have, you're standing on their shoulder. A lot of these kids have not that. So I think that we do sometimes have to come bottom up and work with some of those families that are gone. And I agree 100% with you. Most of those addicts are suicidal. They want death. I got caught up messing with white boys and the hippies. Believe it or not, I was a hippie. They introduced me to it. But I was dealing with mescaline and all of those types of drugs, making you psychotic. But once I began to detox myself, and that's what the study showed, back in the 60s and 70s, when you start taking those type of drugs, it made you psychotic. And you had the same symptoms of a paranoid schizophrenic. But then when you start reducing that drug, the hippocampus and the thalamus can rejuvenate itself. So what I agree with you, but I'm telling you that somehow a lot of these families are beyond that approach and need that type of assistance. So we're gonna have to begin to work together with those two issues. And I gotta get the hell out of here.
Hello, everybody. My name is Joe Reavers. I'm a patient of Dr. Chapman, and this is the result from Symposium. I take care of I got a 6-year-old son, 96-year-old mama, and take care of them. And I got to applaud you, Dr. Chapman, because you sticks with me, and I follow behind you. Thank you.
Hello, I'm one of the persons here at Howard University that works with our treatment program. I worked with Dr. Chapman for a while, which is really where I learned a lot about the treatment, not only with Suboxone, but also now with wraparound services. And let me just say, first of all, thank you all up there about to discuss all the options in terms of, in terms of treatment. But I think when you said about the person themselves and kind of developing relationships with people as human to human, that we have to relate to our population where they are. And I do know that that makes a difference when you treat them with respect and you let them know that you're human and we understand it and we want to help you seriously. I had a patient the other day who made a statement. He's apparently been in several places. And he made a statement to me saying that I asked him, why aren't you, following your prescriptions? Why aren't you following this? He said, people do a lot of talking. And he said, the only thing that really matters to me is the action. And that spoke volume. We're here and we are doing a lot of talking, which we have to, that's good. But we have to be about action. And if we really want to provide all the services that this population that we all need the same things, and they need it too. And if we're serious about it, I think all the organizations, providers in the city, starting right here in Washington, D.C., need to work together. I understand funding, we all need funding, but we have to reach across to each other, be willing to communicate and not compete with each other in order to help. And if we start here in the nation's capital, it can spread across the country. So we need to be serious about working with each other as well and not just operate in silos, because that's really the only way we're going to really be able to get a hold of this epidemic. Thank you.
So I want to give people on the panel a chance to make any last. But is there a question back there? Okay.
I was scheduled to speak later on anyway, but I just wanted to say this because I was sitting back there with a friend of mine. And typically when we see these types of symposiums and information is being given out in such a way that it's supposed to help, my friend and I were back there watching you and Dr. Chapman interact. And the thing that struck us was, in spite of you not wanting to go back and forth, it ended up that way. You understand? Because I'm sitting back there. And that's not to attack anyone. The purpose of this symposium, see, I was telling somebody last night, pain and death are great motivators. Love is the only resurrection. And what I mean by that is, what you see right here is the resurrection. It's the beginning. But if we come in and we continuously have a dialogue that seems like a debate as opposed to a dialogue, then where does that take us? Because both of you have valid points. Both of you have information that's important. But what we don't want to do is go back and forth. I, too, am a client of Dr. Chapman's. He invited me to speak because, like you know and he know, most drug addicts are articulate and intelligent. See, it takes a certain amount of intelligence to get up every morning and go in the street and find a narcotic. That ain't an easy business for those that have been on it. You understand? It takes some creativity there, and what I was going to speak to later on is what the brother Catfish was saying. I understand the abstinence piece, I really do. And I understand Dr. Chapman's perspective in terms of medication, because the point was, when you medicate someone, the objective is to get them off it eventually anyway, is it not? Not to retain it. So it takes us to your piece, which is abstinence. Am I correct? That's the ultimate objective, okay? Now, in each of these individual spectrums, we just have different ways of getting there. I deal with Dr. Chapman. Over the years, he has developed a team. Now, this team creates, when you go in, there's a dialogue that takes place. That ain't just about the Suboxone protocol. He deals with this thing from a mental and physical perspective. If you go in and you see a psychiatrist, a therapist, and a social worker, they make adjustments to your needs, and we go from there. It ain't just about the Suboxone. See, I don't want to get lost in that. The thing is to correct a wrong, to move forward. And I appreciate both of you with the information. You spoke about children, young people, and their inability to understand where we're coming from. Well, if they live long enough, they will. It took experience for you and I to get to this point. Going back to the pain. See, pain is a great motivator. Either you're going to stay in it or you're going to try to get out of it. You understand? And when you saying that you think people want to, see, people have to have a reason to want to wake up in the morning. I was telling Dr. Chapman that the other day. People have to have a reason to want to wake up in the morning. And in our society right now, whether it's black, white, Jew, Gentile, if you ain't got a reason to get up, you are not going to get up. Getting up means that you're satisfied with your life, you have an objective in it, you have goals, and you're going out the door to achieve those goals. But if you have no goals and you locked into playing Xbox, where is the goal? Do you understand? We have to go back to our own homes. I was telling somebody the other day, when you look at men and women in this society right now, and I'm not a statistical expert, I just go on behavior. Behavior is the most consistent thing on the planet, good or bad. There is no black and white. Behavior is consistent. You have verbal and nonverbal communication. There's 90% of your day, 93% of your day is nonverbal communication. Only 7% of a day is verbal communication. So that means you passing people all day. Body language, all that stuff is important. Now, if you go in a home, most women, young women, are graduating from school. They want a car, they want a job, they want things. A lot of our juvenile men are stuck in the Xbox. You can't even get them to take the trash out because they don't want to leave the game long enough. See, the women ain't locked in like that. So you got to ask yourself, what created that disparity? You spoke about being in prison, and I just want to say this and get out of the way. I tell people in this city, because I can speak about this city, in 1976, the bicentennial year, when they started to build the subways, they brought in Superior Court. All the men in here, most of us were first-time offenders. They were giving out 7 to 21, 8 to 30, 15 to 45, and 20 to life. How can you raise a family if you got that much time and you're a first-time offender? But now let me say this to you as well. Lawton was only 25 miles away, so you could see your family on a daily basis. We had some things in order where buses would come. But it also provided you to be able to continue to see your child and at least participate at some point verbally in that child's life. They had 35, 40 self-help groups. People were coming to Lawton looking for answers. So the government stepped in because at one point they didn't want to have nothing to do with it. The government stepped in and took it over. And that's another issue, but for every issue there's always an A, B, C, D, E, and F. And we are always affected by it. We have to find out, prioritize what we want to do, how we're going to do it, boots on the ground, and get it done. I'm loving this symposium. When I get up there, what I want to know is, when we talk about boots on the ground, I took anthropology when I was in college. That's a study of nature. You go in, you study things. I understand that most people get data on a yearly or a 6-month basis. I'd like to know, because I can speak to DC. It's very small. I want to know, can we go into Southeast, Northwest, all these different areas, identify a subculture because that's what we classified in there as, a subculture within a culture that we think that we can't identify with, but we can, because those young people that's out there hustling and killing, or we can identify with them. and they will let us if you allow us to communicate with them. See, you can't sit in the office and see them one day and think that you understand them. So you got to have some people that's there every day watching them where they feel comfortable enough to come and talk to you. Because the greatest thing we do know is word of mouth is a great transportation when you're talking about ideas. You get an alpha male in that neighborhood, and he starts to spread that information about you got some people that's trying to help these young people. Trust me, they'll show up at your door. Thank you.
So I just want to maybe end on just listen to the conversations today. I think my brain automatically went to how we treat diabetes. So diabetes was an epidemic years ago, and what we learned very quickly to see success in the diabetic population, it has a lot of cultural implications as well for the African American population, is that we quickly understood you needed primary care, you needed a dietitian, you needed the pharmacist, you needed to be able to address any psychiatric problems with those patients that led them to maybe overeat, so diabetes and maybe obesity as well. We needed a collective interdisciplinary team to come together to address everything that went on with that patient to get their diabetes under control. And there was a similar thing, I think, when I think of medication treatment with diabetes, people were afraid of insulin. They were terrified of insulin. No one wanted to go on insulin. And so when I think about the discussion today, I automatically think about some of the benefits or some of the great strides we've made with diabetes, and I'm hopeful that this similar approach with Dr. Chapman and different folks are doing, that we'll have success as well. But we have to come together and address all the different aspects that are leading that patient to where they are at that point in their life to be addicted or to be in pain, or to whatever we have with that patient. We have to look at a comprehensive approach. And so I feel like if I'm more hopeful than I was coming in today, listening to everyone present. So.
I want to, let me say, I've got the ultimate respect for Doc. This dialogue that he and I had today, it happens in my office every day. I hire people to make sure that they keep us fresh about what's going on. I'm from the old school. I don't want to lose the identity of my model to a national model, because I think cultural specificity is critically important when we talk about areas of emotional pain, double consciousness, survival skills, defense mechanisms. They need to be all included in treatment. But I want to respect, I listened to the young man a few minutes ago. He has the highest respect for you. And if you came to St. Louis, you probably hear someone say that about me also. We worked hard.
I was born in St. Louis.
Okay, so we worked hard.
Hospital.
Oh, good.
Master's is on my, Master's in Johnson
Yeah.
is on my birth certificate.
We have worked hard to establish credibility within our community, that people respect us and listen to us. And it's incumbent upon us to pull together and use the skills and training you've got and the skills that I got. Hopefully, I listened to the young lady who said, we got to come together and do a town hall meeting that we can talk about some unique strategies we used, and that medication, there's a place for medication-assisted treatment. I know that. They got this thing, state-targeted response in St. Louis for medication-assisted. I got 20% of my clients going there. But I want to give them an option, a choice. If they don't want to go, let's try this, and this is a support system in place. But I respect you, and I respect the work that you've done, and I'm glad I got a chance to meet you. Maybe we'll get together, you come to the Loop, to the Gateway, I'll invite you down there, and we can have some
Yeah, I'll give you a little background. My grandfather was born in Lynchburg, Virginia, 1869. I often wondered how my father and I were born in St. Louis, but you can figure it out. We're escapees. And I'm still running, you know, and still raising hell. So, but no, this has been a beautiful conversation, and it's really what we envision coming back to Howard in bringing all of the schools together. So if you look at this program, you have the law school, the School of Divinity, the School of Social Work, School of Allied Health, the medical school, the School of Pharmacy, of course, all wrapped around this issue And that was the vision. So we also have a network of churches in the Washington metropolitan area, because once we get that patient stabilized medically, they need everything that you've talked about. And that's what we want to do. But we can't do that without bringing in the social determinants of health. And so the School of Social Work, I was on a panel with her 2 or 3 years ago. I've been to the School of Social Work. I was in Cook Hall in undergrad school, never went in the School of Social Work until 2 years ago, and actually sat down and presented this to the dean. So we're all on the same page, and that's what this is all about. We need the entire, this is the village that we've been looking for.
You can look for a phone call. Edwards.
This conversation has to continue. It can't stop here. And I'm really grateful that it began here at the Mecca, because this is about us, this is about our families, and it's our collaboration and understanding of each other that's going to help address this problem.
And I wanted to thank all of the panelists, members of the audience. I completely agree. This is a problem that we all need to be working at together. And we need to be bringing our different perspectives to bear. And how are we going to develop the best solutions? How are we going to make use of the strengths? How are we going to address this problem and make things better? And I'm convinced that we can do it. And we can do it by working together. We can do it by having honest, open conversations and thinking about, what did I hear? What did I just learn? How do I incorporate that? How do I bring it in? And I want to thank Dr. Etienne for organizing this conference and inviting everybody here. So I think that if I've got it right, marching orders, that we're now going to take a break for lunch.